I think we can start, Jiren bhai.
Okay, we are live now. We can start.
Okay, good evening, friends. Welcome to the 16th POSI webinar. We are really fortunate to have our esteemed faculty, Dr. Jennifer Tao from Alfred DuPont, USA, with us. Now, I request our moderator, Dr. Rujuta Mehta, to introduce our faculty and our panelists. Thank you, Rujuta.
Thank you so much, Dhiren Bhai, and welcome all POSI members and non-members who are attending this webinar. As we continue to charge ahead in this sharing knowledge experience, I think we are very lucky to have two very dynamic president and secretaries who are keeping us all sane and grounded in this lockdown. So without much further ado, let me introduce our charming speaker today. That's Dr. Jennifer Tai from Alfred DuPont Institute, which is known as the Mecca of Pediatric Orthopedics in the USA. When I go through her CV, I see a lot of credits of all myriads of natures. She has also been educated in biology, anthropology, which made it very interesting for me. And all her medical training has been at the UCLA and then fellowships at Harvard and Boston Children's. She is currently the present pediatric orthopedic surgeons at the Nemours Alfred DuPont Institute for Children and even at the Christina Care Department of Orthopedic Surgery. Her awards and honors and membership to societies are really exhaustive, but she's been listed amongst the Delaware top doctors for 2018, which is very outstanding. And she's given absolutely several national and international lectures. Her forte is, of course, upper limb and brachial plexus, but she has some very interesting research in osteogenesis imperfecta as well. So virtually probably the entire gamut of pediatric orthopedic conditions, but a special place in the heart for the brachial plexus and the upper extremity. So without much ado, let me allow the screen space and time now to Jennifer, who will be taking us through the basic approach and decision-making and how to handle shoulder sequelae, which is the commonest problem a lot of us face in brachial plexus injuries. And our two dynamic panelists, Dr. Maulin Shah and Dr. Praveen Bharadwaj from Coimbatore, Maulin from Ahmedabad and Praveen from Coimbatore, they'll be regaling her with cases after the audience question answers. So let's start. We can ask Jennifer to start screen sharing, please. Over to you, Jennifer.
Yes, thank you so much. I do want to thank you for this wonderful opportunity to talk about a subject which was near and dear to my heart, brachial plexus and the shoulder and brachial plexus birth palsy. So thank you very much for that kind introduction, as well as this wonderful opportunity. So why is this topic important? Well, there's been a lot of things going on right now, and I'm sure you're familiar with all the Facebook conspiracy theories about everything that's been happening. And so there's actually a little bit for people who are interested in things. Brachial plexus birth palsy has actually been postulated as a cause of World War I. So this gentleman is Kaiser Wilhelm II of Germany. He was known to have a weak and short left arm attributed to an Erb's palsy. There's some thought that he blamed the British doctor who attended his mother, who was Victoria, daughter of Queen Victoria, for this and had some enmity towards the British. And also that maybe he was very aggressively militaristic as a sort of a Napoleonic complex due to his arm. And he's oftentimes, interestingly enough, in portraits and photographs posed almost hiding some of the sequelae that you see with brachial plexus birth palsy, meaning that shortened and internally rotated left arm. But going back to maybe more practical, more modern day reasons for being interested in brachial plexus birth palsy, it is a significant source of both parental and physician angst. The incidence of these conditions may be rising with the sort of global incidence of increasing obesity in women, which has an association with increasing obesity in babies and macrosomia at delivery. There is definitely known to be a lack of full recovery in some patients, and this does oftentimes lead to long-term shoulder sequelae that will be the focus of today's talk. So I'm not going to belabor the basic of brachial plexus birth palsy, but it's a flaccid paresis of the upper extremity attributed to traumatic stretching occurring at birth. The incidence is somewhere between 0.4 and 1.6 per 1,000 live births. And what do we know about brachial plexus birth palsy? Well, the vast majority of these are transient. There's anywhere between 7 to 95% chance of spontaneous recovery. And we'll come back to, well, why is that such a broad range of natural history recovery? We do know that infants who essentially have some of the more milder neuropraxias who recover anti-gravity biceps in the first couple months of life should have full recovery by age 2. We also know that infants who do not have early nerve recovery may benefit from microsurgical reconstruction. And we know that many of these infants will have shoulder sequelae, which, as I said, will be the one of the focuses of this talk. What's not known? Well, an awful lot is not known. So this is a recent PubMed search, and there are 831 results if you search brachial plexus birth palsy. The vast majority of these are focused most recently, with most of the research happening recently. And if you do brachial plexus birth palsy plus the shoulder, you get 110. So this is an active area where we may not fully understand brachial plexus birth palsy, and people are actively doing a lot of research in this area. So one of the interesting ways of looking at shoulder dysplasia, so I'm an upper extremity surgeon, I'm also a pediatric orthopedic surgeon, and so you can look at shoulder dysplasia and brachial plexus birth palsy as in some characteristics similar to hip dysplasia and CP. So we think there is a normal joint at birth, although there are some rare instances in cases of reported associated proximal humeral trauma. And that overall, the muscle imbalance of stronger internal rotation versus weaker external rotation seems to lead to progressive glenohumeral joint deformity. Although, again, we're going to circle back to this at the end of the talk. Maybe there may be other contributing factors as to why this occurs, and maybe it's not just simply weak versus strong muscles. And that there's this typical pattern where, because of the preponderance of upper plexus lesions, that you have internal rotation contractures of the shoulder, decreased glenohumeral motion, and increased compensatory scapulothoracic motion. And one of the interesting things, and we're going to come back to this later, is that you can't really compensate for lack of glenohumeral motion. So if you have a glenohumeral internally rotated contracture, your scapula runs into your thorax. You can't really further accommodate that lack of glenohumeral motion via scapulothoracic motion. But perhaps if you have some stiffness of the glenohumeral joint in external rotation, you can, in certain circumstances, compensate with increased scapular thoracic motion. So, well, you know, as orthopedic surgeons and others interested in this field, how do we assess the shoulder dysplasia? Well, there's a number of ways of measuring this via radiographs, although as we'll talk about in a moment, it's in some ways not always so simple. People have been very interested. I have the great fortune of being at an institution with a very well-established gait lab. So we do a lot of motion analysis for lower extremity. People have tried to look at motion analysis for some of these upper extremity conditions, including brachial plexus birth palsy, although there's some challenges to that. And then again, as physicians, we go back to the basics with physical examination, which gives us a lot of information as to what the situation is, gives us a lot of information as to how we can address some of these shoulder issues. So what is affected in shoulder dysplasia? Well, quite honestly, everything that people have looked at. So what is most well studied is the glenoid retroversion. So it does seem like in this typical internal rotation contractures that you have bony changes happening at the glenoid level where the glenoid becomes more retroverted. People have also looked at humeral retroversion. So the humerus is actually retroverted about 30 degrees, and this seems to have decreased retroversion in brachial plexus. There are humeral head changes where the humerus becomes flattened, and Nath has described this shear deformity, where there's a combination of scapular hypoplasia, elevation, and rotation, where the entire shoulder girdle seems to be rotated. Now, what is a little bit challenging is that this really does require, for the most part, some sort of axial imaging, and axial imaging can be difficult in the young child, particularly because that proximal humerus can be very cartilaginous in young children. So then you're considering obtaining an MRI, which frequently requires sedation to get good quality images. There's some sort of controversy and challenges about how to position the arm to acquire these images and how to measure them. The normal changes. So there are normal changes that happen where infants tend to be more retroverted, and you become a little less retroverted as you get older. So trying to compare longitudinal changes can be challenging, and that there's even differences in dominant and non-dominant sides. So looking at one side versus the other, and as our sports medicine colleagues have noted, this can be activity related. So throwing athletes may actually have changes. So trying to just compare, well, maybe we can just compare it to the contralateral as a quote unquote normal, maybe we can't. So again, what's been most studied is the glenoid retroversion. So glenoid version is age dependent. Again, you're most retroverted when you're younger, and you get less retroverted as you get older. And people have looked at this using MRI, CTs, and arthroscopy as reliable measures. And people look at the percentage of the humeral head and here to the scapular line. People also look at this sort of tangent and 90 degrees minus this alpha angle, meaning being the degree that the glenoid is retroverted. And this is Waters' classification system, where he's really tried to categorize these deformities, looking at essentially a normal glenoid versus having a certain more than 5 degrees difference compared to the contralateral versus posterior subluxation of the humeral head versus maybe the development of a presence of a false glenoid, much more severe changes, and posterior humeral head dislocation in infancy, which we'll talk about in one of the cases. And again, we do know that the natural history is such as that as you get older, these glenohumeral deformities increase with increasing age. Again, people now have also looked at humeral retroversion. So the humerus is naturally about 30 degrees retroverted, and you get less retroverted in children with brachial plexus birth palsy. And being less retroverted is sort of the same as saying more anteverted. So again, you have more internal rotation compared to the amount of external rotation. And again, there's some controversies as to how this can be measured, particularly in those young children with a not fully ossified humeral head. And again, people have also noted and described that there is actual humeral head deformity. So this is a description of the skewness, trying to get a calculation of how deformed, how flattened that humeral head is. And all these bony changes make up brachial plexus birth palsy. And in addition, again, NAF has described where it's, again, not just really happening at the glenohumeral level, but the entire scapula, as he's described, becomes hypoplastic, elevated, and inwardly rotated. So there's a lot going on in terms of what constitutes the skeletal changes in a long-standing brachial plexus birth palsy and the shoulder dysplasia. So can we quantify this using motion analysis? So it's nice to get objective data, particularly we're going to talk about some of the interventions that we make, are the interventions that we're doing helping? And unfortunately, this still remains to be a challenge. It's an area of active research. One of the problems is parsing out scapulothoracic motion versus glenohumeral motion, whether you can reliably count on the skin markers, whether the scapula simply moves underneath the skin, how you can position the cameras to do the motion capture that you need for some of this analysis. So although it's a very intriguing area, it still remains to have some challenges. So what do we fall back on? Well, we fall back on, as physicians and surgeons, some of the physical examination. So the Mallet classification system has been now modified several times. Most recently, and intriguingly, what has been added is this the 6th measurement of internal rotation. So previously, as most of the problems with brachial plexus birth palsy having to do with longstanding shoulder issues really have to do with lack of abduction and external rotation, a lot of these really focus on external rotation. Hand to spine was the one measurement which did, in fact, try to look a little bit at at internal rotation, but looking at some of the motion analyses that have been done, it really is not pure internal rotation. It requires some abduction of the shoulder in order to clear the hip, as well as some extension to get the hand to the spine. And so people have really been looking at internal rotation, looking at whether you can simply touch your belly and how much wrist flexion you need to touch your belly, whether it's possible or not. So again, I was asked to really present this in an interactive way, looking at cases. So I thought to pull 3 very kind of typical problems, very representative cases that you tend to see with shoulder issues in brachial plexus birth palsy. So the first I have is a 5-month-old female infant who's referred to me for brachial plexus birth palsy involving her left arm. The history is that she was induced vaginal delivery that was complicated by shoulder dysplasia at 38 weeks, and mom interestingly was diagnosed with gestational diabetes the day before delivery, and the baby's birth weight was known to be 9 pounds and 13 ounces, so a macrosomic infant with shoulder dystocia, very common history they might have. And she's coming to me at 5 months, but they deny having a history of fracture at birth. The family reports that the baby was able to move the hand and the wrist normally at birth, and they've been followed by physical therapy, they've been followed by neurology, and they're in PT. So consider what to sort of focus on in terms of the examination with this child. Okay. So really one of the most important things to focus on is external rotation, particularly passive external rotation. So this infant was only able to externally rotate to neutral. And this is actually not photographs of this particular infant. This is a from Mary Beth Izaki's paper looking at some of these issues. So you can see, but it's very representative of my infant in that they have a shortened arm, apparently shortened arm. They have deep creases, and they have this very deep axillary fold. Interestingly, this baby is able to flex against gravity, but the elbow is really held in pronation, which is a key fact. Usually when we're looking at spontaneous recovery of the brachial plexus, we're looking at anti-gravity elbow flexion in supination to really drill down and focus at what you're seeing is recovery of the biceps versus the brachioradialis, which can help act as an elbow flexor in pronation. And again, this infant does have good wrist and hand motion. So what else do we think about at this point? So really looking at some radiographic look at the shoulder. So I have the great fortune of being able to access ultrasound relatively easily. I tend to go down to ultrasound myself because I do think some of these measurements are very sort of operator dependent, and I like to see how the shoulder is moving under ultrasound. And this is these are images of my infants. Again, the right side is the normal side, the left side is the affected side, and you can see in the normal side, this is scapulospine. You can actually oftentimes see the cartilage of the glenoid pretty nicely. You see the ossific nucleus as well as the cartilaginous head. You can see this is relatively nicely balanced. You can also, and just for reference sake, this is an image where the transducer is going from posterior, which I think is actually one of the easier ways of looking at this. And in that position, you can actually rotate the shoulder and see what happens with both internal and external rotation, because oftentimes maybe it looks a little more sublux in when it's internally rotated, and then when you externally rotate, it may appear to reduce. And this is the affected side. So you see the humeral head. Interestingly, the ossific nucleus looks a little smaller than the contralateral side. And you can see the scapular spine, but you're really losing the glenoid. And you're losing the glenoid because, again, this is an infantile dislocation. This baby at 5 months of age already has a dislocation. Now, this has been described as a in a way, a surrogate for looking at both whether the shoulder is reduced or not, as well as looking at some of the version, but most people do recommend getting additional imaging. So this infant did have actually had additional imaging. So at 3 months of age, again, this infant was being followed by neurology, and they had an MRI, which again, the normal side is the right side, really nicely formed, retroverted because it's a baby, but you see on the left side that the shoulder is in fact has an infantile dislocation. So options for treatment at this time. So there's a variety of different things that you can do. I chose to take the child to the operating room to reduce the shoulder. So again, I do have the benefit of some wonderful colleagues, and some of my wonderful sports colleagues spend a lot of time doing arthroscopy of the shoulder. So when I'm looking at these infants and trying to do any sort of arthroscopy, I will oftentimes enlist their assistance with regards to things. So they had an arthroscopic anterior capsule release, a release of the middle glenohumeral ligament, a partial subscap release, and then at the same time, I did perform some nerve transfers, the spinal accessory nerve to the suprascapular, and branches of the ulnar nerve to the musculocutaneous nerve. So I tried to do the video, but I was a little worried it wouldn't present well. So these are some static images, but you're seeing the humeral head. You're actually not really seeing the glenoid very well because again, this is essentially posteriorly subluxed and there is the presence of a false glenoid. And when we distract the joint, you can kind of see that there is the true glenoid and sort of this ridge and a little bit of a false glenoid, and with and that the shoulder wants to sit outside like that. Okay, some additional images of the actual release. These are very small infants, so the shavers and everything always look huge. The anterior capsule as well as that middle humeral ligament being released, and then the partial release of the subscap muscle. And it goes from being very tight and very hard to see where you can actually get some better distraction of the joint. And again, you sort of see this is the true glenoid in this area as opposed to that false glenoid. Afterwards, the infants are placed in the shoulder spica cast for 4, sometimes to 6 weeks. And then typically I convert that shoulder spica cast into a brace. So it gets sort of bivalved and converted with some Velcro straps into a brace that the infant can come in and out of. And I did actually see this child fairly recently. A few months ago, she's now 5, and she actually, for a child who had this infantile dislocation, scoring quite highly on her Mallet classification, not only in the sort of external rotation measures, but also in internal rotation again. Now, interestingly, she does, and we're going to come back to this point, she does have a lot of winging of the scapula with cross-arm abduction. So I have to say, I sometimes wonder whether, very likely her glenohumeral joint remains stiff, but whether with everything that's happened, now she's a little bit stiff in an external rotated position, which can be a problem in some children. But because we've done this very minimal approach, we haven't taken down a lot of the internal rotators, she's able to compensate by winging the entire scapula to get midline function and cross-arm adduction. Now, what's a little bit less clear to me is, what is going to be her natural history? Is this going to be problematic more than somewhat of the cosmetic issue right now? There are reports of children with brachial plexus birth palsy having pain. Could this abnormal scapulothoracic function be a source of pain in the future? Again, one of the somewhat unknowns at this point. Other treatment options. So other treatment options would be things like Botox and shoulder spica casting. So I think in a child with a neonatal dislocation, it's probably asking a little bit much to try to do a closed reduction in this case. So I'm not sure that this will be the ideal candidate, but people who have looked at maybe some of the more milder instances where there's earlier signs of subluxation and tightness and external rotation have found success with Botox and spica casting in those situations. So if you have maybe some of the reports have suggested if you have at least 30 degrees of passive external rotation, that Botox and shoulder spica casting can be helpful in that situation. Although again, a lot of these children do continue to have long-term differences with regards to their shoulder despite that. Or the sort of the classic would be a open procedure. One of the issues with doing an open procedure is you have to take down a lot more. And potentially by taking down a lot of these internal rotators, do you potentially burn bridges in terms of some of the opportunities for intervention later on and cause some of the internal rotation weakness. So moving on to a second very common scenario, a second case, is a 3-year-old male who presents with a brachial plexus birth palsy involving the right arm. They've had, they're in PT, but they really have had no previous surgical treatment. So again, on examination, this child is scoring around Mallet grades 2s and 3s for their for most of their things. You can see really externally rotate the arm very well, has trouble with abduction, has trouble with things like putting his hand to his back. But what's missing in this evaluation? Well, what's missing is that 6 score, that internal rotation. I think this is really critical in terms of thinking about what the options are for treatment, is looking at what the strength of internal rotation. So again, he scores pretty well on internal rotation. You can actually test the strength by having the kids put their hand to the belly and asking them not to move it from the belly, and you can actually check the strength of it. And also looking at least at passive external rotation. Passive external rotation for this child in adductions around 25, and in 90 degrees of abductions around 40. So again, most of these children benefit from additional radiographic assessment. The very young children, because of the cartilaginous humeral head, I tend to recommend an MRI. But in the older children, it's more radiation, but because the study is shorter, easier to get a CT scan. And you can see on the left that the has a very normal appearing shoulder, and on the right you can see that there's some mild changes with increased retroversion of this shoulder. So what are the treatment options in this child? So a child who has essentially lacking external rotation, has good internal rotation strength, is a good candidate for some of the soft tissue procedures. So this child underwent an external rotator tendon transfer. The lat and the teres were both transferred to the rotator cuff. My practice is to check external rotation both in adduction and in abduction, and if it's less than 30, consider a lengthening procedure of either the subscap or the pec major. And this has been described in a variety of different ways. I like to do this by doing a medial approach to the scapula, really start making a pretty minimal incision and releasing it off of its origin in terms of things. And then he goes into the shoulder spica cast. This is actually post-op day 1 in the morning, went to look for him rounding. So although the casting is a little interesting for the families, the kids actually do pretty well with it. And this is in post-operatively. You can see that he has significantly improved ability to externally rotate, which influences his ability to get his hand into space. You can see, however, that he continues to have compensatory scapulothoracic motion. You can see the winging of his scapula when he brings his arm out. But this has been studied and has a very good track record with regards to improving malaise scores, improving functional ability, potentially stalls the, prevents further deformity of the glenohumeral joint, has not really been shown to reverse some of the changes, even when done at a relatively young age. But what should we be watch out for? We really need to watch out for loss of midline function. So I think it's very important that you check for the presence and the strength of the internal rotators, because it is not that helpful for the children if you increase their ability to externally rotate, but they lose midline function. You need midline function for feeding, dressing, self-care, and if they have a lot of difficulty, they may not necessarily be as good a candidate for this, or if they can do it, but they seem to be weaker, or they need a lot of wrist flexion to achieve placing their hand in the belly, considering not taking both of the internal rotators, so not taking either the lat or the teres, and not both, so as to not lose some of that strength and function. So this is my final case. So this is case 3. It's a 6-year-old male who has a brachial plexus birth palsy involving the right arm. He has not had much in the way of previous surgical treatment, and has not had much in the way of physical therapy for quite some time. And so his exam, on his exam, he does have good internal rotation, lots of difficulty with external rotation, a very markedly positive Horner's sign. And so for further assessment, he also had a CT scan. And this is the normative side versus the abnormal side. You can see how there's significant bony changes occurring. And really, this is the greater tuberosity. So the articular surface is really very flattened. It's very pointed very posteriorly. There's some matching flattening and retroversion of the glenoid. So someone who it has much more significant bony changes as part of their shoulder dysplasia. So these are good candidates for humeral osteotomy. So this one was done some time ago. So I actually tend to do this a little bit more proximal now, but he was externally rotated about 70 degrees. I do think it is important to make sure that they can still reach their mouth and their abdomen while on the table. So typically I might do this osteotomy, do one screw as provisional fixation, and then actually check the range of motion to see that they can get their hand everywhere we want. And again, this has also been shown to significantly improve global shoulder functioning in kids with brachial plexus birth palsy. So kind of how I do it more typically now, where I try to keep the insertion relatively high. There's some thought that if you stay above the deltoid insertion, that might help with strength. And again, I can't really emphasize enough the ability to reach the mouth and the abdomen on the table before you leave the OR, to make sure that you have not given up that internal rotation. This can be, I really focus this talk on some of those typical changes with the shoulder dysplasia, but there's a lot of other changes that can occur, one of which is they tend to have that abduction contracture, so you can do a slight closing wedge to help with the abduction contracture. Some sort of helpful tips would be to really consider shortening slightly. Oftentimes this arm does not grow as well, so it's shorter to begin with, but by shortening the bone, you take the tension off the soft tissues. And people have described doing this via a medial approach and a medial incision, or curving the incision right at the level where you are planning the osteotomy for cosmesis. That the medial incision is hidden more, and that if you curve the skin incision, then as you rotate the arm, it then becomes a straight line incision. It's maybe a little bit more cosmetically acceptable. So, okay. But really, these are salvage procedures. So again, I was asked to talk about shoulder dysplasia and some of the ways we treat this, but in reality, we're treating it after the horse has left the barn, if you will. So we have this joint, which is, again, is relatively normal at birth, and it goes through these changes, and then we have to fix this problem. So in reality, really trying to prevent some of these problems is probably the best treatment of all. I like to monitor these infants. So again, I started the talk saying, well, the natural history is anywhere between somewhere 7 to 95% chance of a good result. And so if you pick up, if you're monitoring infants, you're going to probably see a bunch of kids who are never going to need surgery. But it's something which, if it's sometimes it's not necessarily picked up on the importance of the shoulder and what we should be doing about the shoulder. So I really try to see these infants as close to birth as possible, and counsel the family with regards to stretching, bracing, and a very intriguing component might be medical management. Okay, so really focusing on external rotation stretching. So sometimes families are a little overwhelmed. There's a lot going on with the arm. What should they do? And I basically tell them, look, if you're going to do one exercise with your baby, work on external rotation. So both in adduction, the sort of still big position, and that stop sign. Every time you see your infant, stretch your infant. And again, these are infants that I monitor closely to look for loss of external rotation. If they have a loss of external rotation, I consider an ultrasound. If they are, and consider, and again, picking up this loss of external rotation early, you can consider Botox and casting in those situations. Also, if they have a sudden change in how much external rotation, really consider that maybe that might be one of those infantile dislocations. Some studies, Michelle James's work shows up to 30% of the children that were referred to, again, a tertiary level institution, had significant shoulder subluxation or dislocation during the first year of life. And it has been reported as early as a couple months of age. So something to really watch out for. And then I thought this was very interesting. This is out of British Columbia Children's Hospital, where they're looking at splinting. And this work comes, I think they mentioned in their some of their literature, basically comes from looking at how we address other problems, in that early infancy. So looking at hip dysplasia, that we splint hip dysplasia, and also looking at for clasped thumb, that somehow splinting a clasped thumb may allow those weakened and overly stretched out muscles to have some recurrence. So there's some early literature out there. There's actually some both Seattle Children's as well as British Columbia Children's Hospital has some online papers on how you can actually make this, well, maybe not home, but close to home. And really, there's two components. One is a neoprene, something that goes on the baby. They do like to have the strap that goes between the legs so that it doesn't inch up and maybe decreases the risk of having sort of smothering sorts of issues. The arm has a hard splint in extension. I think initially they described that they had the elbow in flexion, and they're concerned that maybe that they would have some associated elbow flexion contractures, and Velcro straps that then really keep the arm adducted and externally rotated. And in their pilot studies, they suggested about 22 hours a day for the first month, trying to get this on as soon as possible before some of those changes happened, and then leaning to sort of a nights and naps program. And there's some ongoing research. Again, it's a hard thing to study because you're taking all these children who have differences going into the study and trying to get longitudinal information via axial imaging can be very challenging. But at least anecdotally, there's some talk that maybe this can be really helpful. So again, an out splint and in splint, you can see as you externally rotate the arm and keep it in that externally rotated position, the shoulder does reduce. And anecdotally, they suggested in their experience that perhaps there's a decrease in the need for reconstructive surgery. I can say, and again, this is very anecdotal, but in my practice, I really hound the families to focus on external rotation. The therapists that I have the fortune of working with know really to emphasize external rotation. And I do use the splinting. And I have found that it does seem, again, that perhaps the glenohumeral joint still gets stiff, but the children can compensate for that stiffness when they're quote unquote stuck in some degree of neutral or external rotation by winging that scapular forward. Whereas when it gets stiff in that internally rotated position, you get a lot more of these bony changes, and that you really can't compensate with scapulothoracic motion. Although again, some of the questions down the road is if the children are doing this winging to try to do the cross-arm adduction and some of the internal rotation, what are the long-term effects of that? And I think that's a little unclear. We do know that in children who are basically stuck in external rotation and really don't have internal rotation, that they benefit from some lengthening procedures of the external rotators or some repositioning osteotomies. But in this situation where they are not lacking internal rotation, it's a little less clear what the natural history is. So this, I think, is very intriguing. And lastly, I'd like to close with just a brief word on medical management. So it sounds kind of crazy. So you have this physical problem, and we're going to give you a pill that's going to fix it. And it sounds incredibly incredibly sort of sci-fi-ish to me. But Roger Cornwell has actually dedicated a lot of time over the last decade to looking at these contractures and what causes these contractures, and are there ways of treating these contractures. So what's interesting is I started this by saying, well, the prevailing theory is that you have sort of normal or strong external rotators and very weak internal rotators, and that causes the problem. Well, that may not be causing the problem. So he has looked at a mouse model where he's taken some newborn mice and sectioned their external rotators of their shoulder. And he doesn't actually find that they develop the typical internal rotation contractures, even though they obviously have no external rotation and only internal rotators. And there's some thought it's because of those are normal muscles. So in his second models, he's actually given these newborn mice brachial plexus birth palsies and looked at, well, what could be happening? What is causing these contractures? And he's really been able to parse out that there seems to be impaired longitudinal growth. He's looked at, well, why is there impaired longitudinal growth? And it appears to be that there is increased protein degradation and relatively normal protein synthesis, and that seems to be one of the factors that lead to the contractures. And interestingly enough, he has been looking at whether there's ways of affecting this protein degradation. So bortezomib is actually a chemotherapy agent. It's used for multiple myeloma, among other conditions. It is a proteasome inhibitor. And in the mouse model, he has found some evidence that giving these newborn mice who have had this denervation in injury seems to restore normal muscle growth and seems to be associated with decreased contractures. So again, looking at the normal versus the abnormal, where you can see these this in contractured, and then looking at if they're given this bortezomib, what happens, and they seem to have not have as much in the way of contractures. So incredibly intriguing that potentially there could be some medical management. And what's even more intriguing is, would this be amendable to translating it to some of the other conditions that we treat as orthopedic surgeons that result in contractures like CP and maybe clubfoot or some of the other things. Again, very much at the basic science level. I'm definitely not recommending off-label use of this at home. It is a chemotherapy agent, and it's very unclear what happens if you give children a proteasome inhibitor during early infancy in terms of what side effects and other effects you can have. So, but I would like to emphasize really the best treatment is prevention. So although there are ways we can try to address these shoulder sequelae in brachial plexus birth palsy, really trying to identify these children early, whether it's via outreach. Some of the splinting is relatively simple. So we've managed to address this problem even in resource poor areas in other areas such as clubfoot and some of the hip dysplasia. So really trying to spread the word and recognize that infants with brachial plexus birth palsy really need to be closely monitored for external rotation and consider either physical therapy or potentially some of the splinting as if you get to the point where you have problems with both in external rotation and weakness of internal rotators, whether it be because they had an open release or other procedures, or because that they had a C5, C6, C7, and they had some weakness in their internal rotators, you really begin to run out of some of the treatment options that we have. And so thank you very much. This is my home institution in Delaware. This is actually some members of my team at the hospital. A special shout out to Tracy Shank. She's one of our certified hand therapists. She shared some of her pictures and things for the slide, and of course to my family. So thank you very much for this opportunity. I really look forward to seeing some of the very interesting cases that I know that you've prepared.
So thank you so much, Jennifer, for a very nice, concise, and crisp review of shoulder sequelae and what you would do. Some interesting things have surely come out of it. I could see Maulin busily jotting down some questions, so I'm sure he has some things to ask. But before that, we have, as we said, that our priority is our audience. So we have some questions coming in from the audience. Dr. Atul Bhaskar has two questions for you. Does winging actually ever improve with surgery or Botox?
I guess my question a little bit is, what do you mean about winging? In terms of, the winging that I see that I was describing really is in so much really after treatment that you have the now you have the winging of the scapula when you internally rotate. So not so much. I mean, there are a lot of other things Nath has described with regards to the what the differences are with the shoulder. I think a lot of the research, trying to simplify the question a little bit more, is looking at things like what happens to the glenoid version. People really have not shown that some of the treatments like early tendon transfers or Botox really changes that necessarily significantly. It's more that you see the improvement in terms of Mallet scoring and function.
So in addition to that, he wants to know whether the rhomboids or the serratus anterior you think are partially involved, and that is what worsens the winging?
Again, I'm a little, I think honestly, I think is that the glenohumeral motion remains abnormal, and that you are really relying on increased scapulothoracic motion, and that is the what you're seeing is you're seeing the scapula move more than you're quote unquote used to. That typically, that normal ratio of glenohumeral to scapulothoracic motion is completely thrown off in children with brachial plexus birth palsy, and to some extent or another, they're compensating, and depending on what their primary problem is and how you addressed it, you're going to see the winging in different ways. Now, again, I think it's an unanswered, it's a really intriguing and unanswered question. It's a conversation I have with families that there are things I know will help with scapular winging. What I don't know is if I do those things to this child who's has had this history of a brachial plexus birth palsy, will I take away their way of compensating? So maybe the winging, I can make the winging stop, but is that going to result in decreased function? And I think that is one of the difficult questions. I think another difficult question is that we, a component of this is that we do know that some of these children and adolescents and adults with brachial plexus birth palsy have complaints of shoulder pain. And is it arthrosis happening with the glenohumeral joint? Is it this compensatory motions and overstretch of certain muscles causing the pain? Is it sort of nerve pain from the original brachial plexus injury? Intriguingly, is it associated with ongoing litigation? There's a study looking at litigation, children who are having ongoing litigation have more complaints of pain. I don't really know, but again, I don't really know. I know that there are techniques that we can address winging. I'm just hesitant to do them in children who have good function with the brachial plexus birth palsy, because I do think it's their way of compensating.
His next question is there any role of combining a derotation osteotomy with a shoulder tendon transfer?
I suppose there probably is a role. People have actually looked at, if you end up with loss of internal rotation after early tendon transfers to improve external rotation, people have actually rotated the humerus back the other way to restore midline function. Most recently, ABZUGS, I think, recently published their series on that. I tend to, again, there's the laundry list when you shared this topic with me and I started looking at what I'll speak about. There's a lot of different operations that people have done for a lot of things around brachial plexus. So I was really trying to simplify it. And in my sort of really simplistic view, I look at it as if they have a good glenohumeral joint, you can power it by doing tendon transfers. And if they have a quote unquote bad glenohumeral joint, if it's too changed, then very simplistically, I think doing the humeral osteotomies and leaving the joint alone is my general approach to things. Although again, people have, NAF has popularized his triangle tilt procedure where he's actually rotating portions of the scapula. People have done sort of glenoid focus procedures. There's honestly a very long laundry list of things that you could do.
Okay. Another question from Dr. Tushar. He wants you to compare and contrast the super splint with the Pavlik harness.
Oh, compare and contrast the super splint with the Pavlik harness. So I guess the comparison is, and again, this isn't, this is kind of, my readings and sort of personal interpretation of the work of the people who developed this in British Columbia, is that you are in some ways doing a very similar, or trying to achieve a very similar thing. You have, you're trying to maintain the joint in a reduced position. And I think the sort of contrast part is, well, in hip dysplasia, there's a multitude of reasons why you can have hip dysplasia, but the imbalance across the muscle forces is, I think, been a lesser regarded contributing factor to this. Whereas in shoulder dysplasia, in some ways, you're addressing, you're trying to, in addition to keeping the joint reduced, you're trying to address some of that imbalanced muscle forces across that joint.
Okay, there's one more question coming in from Dr. Bipin. He says, do early nerve surgeries actually prevent or reduce the shoulder problems?
I think that, again, is a very interesting question. There's a lot of different centers sort of quote unquote bite the bullet and do nerve surgeries at different ages with sort of different triggers of what's happening. One of the controversies I'm aware of is comparing, does the sort of nerve surgery plus later procedures how does that compare to potentially operating on the infants at an earlier age? So I think it's a challenging question to address is how much the nerve surgery versus a younger age may prevent some of these problems.
Okay, a couple of questions from me before I think we have Maulin and Praveen both wanting to ask you questions. What is the youngest age that you all normally do an arthroscopic release? And how would you compare it versus doing an open one, especially if you're going to add ulnar to musculocutaneous and nerve to suprascapular nerve transfers at the same sitting?
So again, I have the benefit of working with some pediatric sports medicine physicians, surgeons who do shoulder scopes and things all the time. So I have to say, I personally would look at a very young infant and be somewhat leery about how do I scope this shoulder because it's so small. You have to, the scope becomes very big in relation to the child, and you have to think about, well, how can I position the babies? These are usually positioned in a lateral decubulus position. Usually I'm there to do other things, and so I'm oftentimes the one who's like positioning the arm and maybe providing some gentle traction. But because they have that long-standing experience of scoping quote unquote normal shoulders in normal sized individuals, they feel comfortable doing the scope. So so I do have that kind of benefit that I'm not sure, as someone who doesn't do ordinarily a lot of scoping in shoulders myself, I'm not sure I would be that comfortable doing it in such a young child because of the inherent difficulties, but because they are experienced, they're able to assist me with that. I will do it as young as we pick it up, because I do think once you see that infantile dislocation, you really need to try to get that joint back, in as soon as you can. And I do think the benefit of doing it arthroscopically is that, rather than having to go through all those internal rotators like the subscap to get to the capsule, you're actually, going from inside out. So you can release the capsule and then see, maybe do a partial release of the subscap. And it is, in fact, I think, less invasive, and that you are less likely to lose some of those internal rotators, which make it so difficult to address later on.
Okay, so there's one more coming in from the net, which says, how young do you image the children? Do you recommend imaging as young as 3 months of age?
So my protocol typically is that the children don't necessarily get imaged unless something triggers the imaging. So I'm looking every time. I try to see the babies as young as I get them referred, and I try to encourage people to refer them to me, literally in the neonatal period. And then I'm doing clinical examinations to monitor them. I'm looking for the anterogravity biceps. I'm looking for what they're able to do at every visit. I'm looking at passive external rotation. And if I begin to get concerned about passive external rotation, I bring them down to the ultrasound suite, and we do a dynamic ultrasound. And again, I think that's a really sort of non-invasive way where you can look at what's happening with that shoulder. You can see, does it look like it's sublux more so than the contralateral, and does it look like it reduces in external rotation? And if they do look like they're subluxing and you're losing that passive external rotation, then again, that might be a candidate for a essentially closed reduction and potentially Botox to those internal rotators. Now, it's really only if they are very worrisome, like if it is in fact an infantile dislocation, I do recommend some axial imaging, like an MRI, to look further. Traditionally, we have recommended an MRI really to look for the presence of myelomeningocele prior to some of the nerve surgery. I think it does give you a little bit of an idea as to whether you have avulsions, and maybe helps you plan things a little bit better. And because you're imaging such a small child, at the same time, that if they get imaging for that reason, then they typically include the shoulders as well, and I get imaging of the glenohumeral joints. Did I lose people?
No.
Okay, sorry.
Maulin, I think that Rujita has lost the connection, so please take over.
So that was great talk, Jennifer. I'd like to ask a couple of questions. the first case where there was, I think, a 5-month-old baby, and
Mhm.
you performed an arthroscopic subscap release and capsular release, and you prefer to do nerve transfer, right?
Yes.
Now, theoretically, we know that the recruitment in external rotators and abductors are last to come in Erb's palsy patients,
Mm-hmm.
and it can come as late as 12 to 15 months.
Mm-hmm.
Now, by performing the nerve transfers this early, are we not giving chance for external rotators and abductors to get recruited normally? That's first question.
Mm-hmm.
And this, yeah, you can answer that, and I ask my next question after that.
I think that's an excellent question. You know, in some ways, the timing of that particular child was dictated by the fact that we were addressing the shoulder joint at the same as well. So I think that's a great question, and the timing of some institutions do surgeries as early as 3 months of age. Where I sort of my background, my training, my sort of experience is around 6 months of age, but I know some institutions wait until closer to 9 months or even older. So I think there's a wide variability, and again, some of the questions are, does earlier nerve surgery result in better outcomes? It is one of those difficult to answer questions. We do know that you are operating on a lot more children if you do this early nerve surgery. So are we sort of denying some of these children the opportunity to quote unquote get better by themselves? And I think that's a very, very intriguing question that it's in some ways hard to answer.
In continuity of that question, we have seen some of the authors, they prefer to do arthroscopic release and tendon transfer as early as 6 months or 7 months. So how would you decide that you would like to perform a distal nerve transfer and not the tendon transfers along with the subscap release? Or you consider nerve transfers in most of your infants? Did you get my question?
So whether you would attempt to get recovery via nerve transfers versus just moving ahead and doing tendon transfers. I think that, again, that's a very intriguing question. I don't think there's a right answer to this, because I think different people are going to do different things, and and you can get to the goals by approaching this in different ways. I think if they're young, it's probably worth a chance at trying to do a nerve transfer to improve their function, because you can always do tendon transfers later on. And obviously, from the point of view of having a quote unquote more normal sort of shoulder function, trying to get as much of their native muscles working, I think makes sense. And if you have a child who's as young as you're describing, they're young and they're in that window where they still have an opportunity. Their muscle hasn't been denervated for too long. There is still an opportunity for recovery with some of the nerve transfers and other procedures, particularly as people are looking into the nerve transfers and potentially some of the greater success of that versus some of the original brachial plexus grafting and repairs.
The last question from my side is, I saw that in case 2, the post-operative position of shoulder spica was in 90-degree abduction and 90-degree external rotation, right? That's the routine procedure you apply shoulder spica in all the patients?
I do apply shoulder spike in all the patients because, at least in all the patients who have a tendon transfer, not so much for the osteotomies, because you're putting a pretty reasonable plate on, and so those are not casted necessarily. But my typical goal, that one might have been a little bit more than I really wanted to achieve. Typically, I go for a slightly lesser than 90, maybe closer to sort of 45 to 60 degrees of abduction and fairly extensive external rotation, so really aiming closer to maybe 60 degrees. So I do appreciate that that one was probably a little bit maybe more so than I typically do. But I do think it's important to protect that repair because you're doing this in young children, and at least the young children that I take care of are pretty rambunctious, and I don't want them to, inadvertently rupture the repair prior to having an opportunity to heal.
Yeah, so just we are worried about exaggerating and existing abduction contracture if we apply the spica in high. So our range of applying spica is around 45 degrees in the cases, especially where they have already existing abduction contracture.
Sure.
Praveen, over to you if you have any questions.
Yeah, Praveen had a question which he had sent me. I think we'll allow him to ask right here.
Hi Jennifer. My one small observation. Many times you had mentioned that you check the external rotation in adduction of the shoulder and abduction of the shoulder. Why you do that, and what is the implication of that?
Well, I think you are looking at slightly different reasons for potentially having a contracture. Particularly, I think, so for example, with the tendon transfers, if they're lacking external rotation and adduction, I tend to focus more on maybe a subscapular slide to try to obtain a little bit greater external rotation. And if it's more an abduction, I look more at the pec. I mean, obviously, it's multifactorial. Multiple muscles contribute to things. It's not that quote unquote pure in some ways. But a little bit where you're potentially looking at different reasons for having contractures.
So generally patients have limitation in adduction, right?
Yes.
Okay. Will that influence your post-op immobilization also, similar to the lines what Maureen was asking? Like,
it's interesting. My training has been that the tendon transfers, the external rotator tendon transfers help with external rotation, but also that you can kind of use them to boost abduction power a little bit. So it's actually placed a little bit high on that rotator cuff, and in part that abduction is to help with that. Now, I do think again they may have an abduction contracture and have that little tendency to keep their arm out to the side, but I guess the trade-off for me in terms of potentially gaining a little bit more power or strength with abduction is in some ways maybe worth it.
Okay, so I think we have about half an hour, a little less than half an hour to go. So let's have the cases because there are quite a few. So thank you so much, Jennifer, for answering so many questions patiently. And Maulin, may I request you to start the screen sharing?
Yeah. Can you see the slides?
Yes.
Yeah, okay. So I'll start with this case. There's a 10-year-old girl. Unlike the typical C5-6 lesions, this girl had good range of active external rotation with shoulder adduction. She had weak shoulder internal rotation in terms that she could touch the belly with wrist flexion of 45 degrees. And she lacks shoulder abduction. When we ask her to elevate the shoulder, she is stopping at around 80 degrees and flexes her elbow. So I'll show the image. She also had some degree of triceps, anti-gravity triceps weakness, and so it represents typically an extended Erb's palsy cohort, which is C567, which Jennifer mentioned in one of his slides. So clinically, this girl has active external rotation and arm adducted of around 40 degrees, as you can see. And as you can see on right side, she needs to flex the elbow, and she has to flex the wrist to reach the midline. And when we ask her to elevate, her abduction, sidewise abduction is around 80 degrees, and she flexes her elbow concomitantly. Now, typically we have seen that when we put an elbow extension splint, their abduction improves to almost full spontaneously. And this means that she does not have weakness of abduction. And this abduction is not forward flexion, it's a true sidewise abduction. So this also signifies that she also does not have pec major and deltoid co-contraction, because otherwise this would not have happened. So these questions are haunting in our minds, that why abduction improves with elbow extension splint application. And we have asked a lot of shoulder surgeons and our colleagues, senior colleagues. One of the theories has come up is when we extend the elbow with a splint, we are stretching the long head of biceps. And the long head of biceps is an important anterior stabilizer. When it's stretched, it lowers the humeral head, and in some way it probably gives anterior stability. And these shoulders are with weak internal rotators. Subscapularis plays an important role to stabilize the shoulder anteriorly. And in absence of that, when we apply this splint, the shoulder is stabilized, and now deltoid can lift the arm. The another theory is there is something to do with triceps length. Once we extend the elbow with a splint, there is adequate triceps length, and that helps in elevation of the arm. I personally do not agree with the theory because why I'll come to that later. But these are the two theories. We know that subscapular is an important shoulder stabilizer, and when shoulder elevation happens, it pulls along with the infraspinatus behind. It pulls the humeral head downwards. That's known as deltoid rotator cuff force couple, and it compresses the humeral head towards glenoid. That's a concavity compression. So what we correlated on ultrasound, that what happens when we apply this splint, we found that as you can see in the bottom, the distance between acromion and humeral head reduces when the child starts doing abduction, and this distance increases when we apply an elbow extension splint. This means that there is something happening which lowers the humeral head with the application of elbow extension splint, probably due to stretching of the long head of biceps. And so we thought that we should do some procedure to stabilize this glenohumeral joint anteriorly. And that's how we started doing pectoralis major transpositioning to the greater tuberosity. We take typically the clavicular part of pectoralis major and suture it to greater tuberosity, way lateral to the insertion of subscapularis. We take it, release it from origin and insertion. We keep the neurovascular pedicle intact and shift the whole mechanism laterally and suture it when the arm is in abduction and internally rotated. And when we adduct the arm, it becomes a taut structure, stabilize the shoulder joint anteriorly. This is above the biceps tendon, and there are different surgical techniques modified on this. And we have seen a series of around 25-30 patients that abduction improves in the range of 60 to 70 degrees. This is the outcome of this girl. And the patients which cannot reach behind the occiput, we have added a lat dorsi transfer. But those patients who have good hand to neck motion, we have done only pec major transpositioning. So this is a different cohort than what we usually see, the C5-6. And these patients, as they already have some external contracture, so that they cannot reach midline, by doing a conventional lat dorsi teres major transfer would not help. And when we compared it with our own group, the average abduction improvement was only 30 degrees. But when we performed this, the average improvement was about 60 to 70 degrees in a study of 25 patients. So we do perform this surgery, and we think that pec major acts as a static stabilizer. As you can see on this girl, there is only 45 degree of elevation before surgery. With a paddy wrap, the abduction improves substantially, and this is 1 year after pec major transpositioning. So we think that pec major transfer has some role in augmenting the anterior stability. That's how it works. So, yeah.
Jennifer, your comments before we move on to the next.
I
And
have
if
to
you don't
say,
mind, Maureen, I may also say something.
yeah, I have to say I'm very, very grateful for this opportunity to really learn from you as a group, because I thought this was fascinating. It was not something that I've really seen before or I'm very familiar with. The results speak for themselves. I guess one of the questions I have is what made you think about this? What made you think of I've never thought to test abduction with the elbow and an extension splint. So what was it some observations that made you kind of drew you down this pathway, or how did this come about?
We run this a comprehensive clinic where we have orthopedic surgeon, plastic surgeon, and physiotherapist. We sit together, and some of these patients we observed that they flex the elbow and they do not abduct. And the therapist came up that when we apply a extension splint, this improves. And so we tried in all our patients, and then we try to go in detail that why this improves. There are a lot of people used to say there is co-contraction between pectoralis major and deltoid, and we have done surface EMG and we found there is no co-contraction. So that's not the reason why abduction is limited. The people say that the triceps length, uh, when you apply an extension split, triceps get longer, and so you can do abduction. But we have seen patients, we have not touched triceps, and still their abduction improves. So I don't think that triceps has some role. And then we thought that there should be a muscle which crosses both the shoulder as well as elbow joint that has to have some role in improvement of abduction. And that's how we came to the theory. I presented this work in Naraka's meeting, and we have been talking to different authors worldwide, Mike Pearl, Roger, for that instance, and they all maybe some motion analysis can help in ident. We know that the elevation improves with pedirac. We know that elevation improves with pec major transpositioning, but we don't know why this elevation improves. So maybe a motion analysis in some way can guide us that what is actually happening at the shoulder joint.
That's fascinating. It really is.
So, Merlin, if I may take you back to and bring you in sort of a thought process about this. I think there have been a lot of people who've been looking into this. Professor D.C. Chuang from Taiwan, who was the first person who really wrote about co-contractions. Whether you do a surface EMG or no, it is what has happened in the child's brain. It is the cortical adaptation. And it is obvious that the deltoid and the pectoral are trying to co-contract. What happens with this is what you've done is the anterior part of the Chuang's transfer, which has been very well described in the 90s, actually. What works here is that the pec now doubles up as an additional deltoid because there's a deltoid weakness, and hence it becomes a strong, powerful abductor. So therefore, it helps you go up in extension until the child actually takes away the co-contraction between the biceps in their mind. Even post-op, many times we see this, that in order to train them back into getting the abduction, you need to block the biceps for some time. So it's a nice observation, Maulin, and a nice sideways thought. But
just one point to add to that.
Yeah, Praveen, if he can add in and then go on to the next case.
Yeah. So, Maulin, that is a very nice thing. And as Madam told, this was part of the Chuang transfer also. But we have seen if you add a trapezius to triceps transfer, the results are dramatic then. Because you have added the triceps power also and you have dealt the anterior instability also.
So I have, so the second set of problem which I found in my patient is now they have good abduction, but as the triceps is weak, they are flexed from elbow.
So next case you can do that, yeah.
So I've started doing lower trapezius to triceps transfer. Yeah, I'll switch to the next case.
Okay, yeah, let's go because we have quite a few to finish.
So yes, Praveen, can you talk?
Yeah. Hi, Jennifer. Yeah, this for everyone. This normally whenever we are reading about the shoulder rebalancing operation, the standard thing what everyone knows is the release and transfer of the latissimus dorsi and teres major for external rotation to the infraspinatus. But this case was put in to bring in the question that whether it is always required to do the transfer or just a release should be enough. Especially in a patient of this age, of 17 years, we feel that many times the adductors would have got shortened in length. And if you try to transfer them for external rotation, they tend to become much tight and still tether the shoulder abduction. So in this group of patients, we do not do any transfer and we just do release of the adductors. So we do almost a complete release of the pectoralis major, leaving only the muscular part of it intact. The latissimus dorsi and teres major release. And instead of transferring the latissimus dorsi to the infraspinatus, it is just tagged onto the teres minor and that lower position itself. So this is just to bring about the point that many of the patients So if we see the deltoid contour in this patient, we can see the deltoid is working well. So it really does not require any much augmentation, and just release of the adductors could improve the shoulder abduction in this group of patients. Jennifer, what is your idea about just a release and not doing any transfer?
I think it's fascinating. Again, you have some wonderful results that you show about this. What this made me actually think about was I also take care of CP, and there's one of my Freeman Miller and I have this sort of ongoing intellectual debate about pronator teres. I do rerouting, he does a release, and so it brings the question of some of those procedures where you do the transfers versus just doing release. How much do you get from the transfer versus versus simply performing the release? Again, I am so grateful for this opportunity to learn from you folks, because it's not something I've ever actually done in my own practice. When I've generally speaking, if I've done the transfer and not just simply release, but you can't argue with the results. And I do appreciate your point that the muscles are very tight, and getting them into that position. And I also do appreciate some of the discussion we had earlier about how you can inadvertently cause more of an abduction contracture, which quite frankly, now looking critically at the case that I presented earlier, you could see that. You could see that sort of that scapula edge winging out when he was in abduction. So it's very interesting.
So what would you have done, Jennifer, had you had a similar case? And what would you have done in the previous case?
So the previous case, again, I thought that was incredibly intriguing. I suppose one of the ways I would have thought about it, not having the benefit of your experience with this, would be, how much of a posterior cord issue maybe the child would have had, in that they seem to have difficulty with abduction, and they seem to have difficulty with extension of the elbow. I definitely wouldn't have come up with doing a pec transfer to achieve those results. I'm not honestly sure that I would have had as much to offer her in terms of how to improve her abduction, because she had good external rotation to begin with. So I may not have honestly had in my hands had much to offer that first child. This child, in my hands, I probably would have considered doing the transfer. So the external rotation tendon transfer, although I may have done a little bit of potentially harm in terms of either causing some tightness or other problems. I mean, I think you've had achieved an excellent result with the release alone.
Okay, thank you. Let's go on to the other one, because I don't think we have too much time left. So that's the result, and yeah.
Jennifer, this is another one common complex problem in Indian situations, especially because patients generally come late. So now this patient was the first consultation when she reported to us, and she has been doing a physiotherapy at home, but no surgeries till now. The patient is 9 years of age. She has got only 90 degrees of shoulder abduction and minus 20 degrees of external rotation. At 9 years of age, what do you offer for such a patient? What would be your treatment option?
So again, I probably would like to also know what her internal rotation strength is and range is. And I'm sorry, I think missed that whether you told me her passive external rotation.
There is no passive. She does not have passive external rotation. Mm-hmm. And so maximum, she goes to minus 20 degrees. So it doesn't even reach the neutral. Even the passive rotation is absent.
And she does have good internal rotation strength?
Yeah, she has a good internal rotation strength.
I probably would offer, I mean, I would consider imaging of the shoulder, but quite honestly, I think her exam probably speaks for itself, in that it's likely that she has significant bony changes, and I would likely offer her humeral rotational osteotomy. with the goal of setting her so that she can touch her belly, maybe with a little wrist flexion, and gain as much external rotation as possible.
For this group of patients, generally, actually, we are very worried about losing internal rotation. So whenever such a child who is plus 8 years, we have done a very aggressive release and tendon transfer, we have generally had difficulty in reaching the midline function. So this group of patients, actually, we have adopted a kind of a two-stage approach. In first stage, we do just the release of the adductors. And this is the result after release. There is no transfer, only release of the adductors. And this provides good shoulder abduction, but still the external rotation was not complete. Next slide, please. So, and at the second stage, to correct the trumpet sign and to get external rotation, we have done a derotation osteotomy of the humerus. And this is the final result what she has. So at first stage, we improved the shoulder abduction by just release and no transfer. And at second stage, we have done a derotation osteotomy to get an external rotation and to correct the trumpet sign. Come to the next one, please. This is the final result of your comments on that approach, please.
I think it's beautiful results. They speak for themselves. I guess my question would be, how much do you gain? You know, she had the humeral osteotomy. I guess how much, if she had just had the humeral osteotomy and not the first stage, you know, how things would be different. And I'm not quite sure, you know, how easy it is to answer that.
Yeah, that is a good. Actually, we tried the other way also, first doing a derotation and then seeing how much it improves. And we saw that the abduction improves as you are suggesting, but not as good as this.
Sure.
So maybe we can do it either ways. We can do first derotation, and then if need be, we can do the soft tissue release. But the one small problem with that way of managing is when you are doing a derotation, you have an perfect control on how much you want to rotate. And you can make sure that you don't lose internal rotation. But when you are doing a soft tissue release, you are not really having control on how much internal rotation you lose.
Yes.
So we first do the soft tissue release, then we know how much of external rotation and internal rotation we have, and then just do the enough of external rotation correction so that she still reaches the center of the body and the trumpet and the appearance is corrected.
So Jennifer, I think we may, just interject at this point saying that the Ganga group actually has one of the largest experiences with what used to be called the mod quad initially. And then the derotation osteotomy was classically only a salvage, but I think over a period of time that this is what they've come to, kind of having their own balance between just a mod quad and doing that. Whereas I tend to do a lot of transfers and glenoid osteotomy as and when needed. So finally, I think at the end of the day, it's important to know for each person what works well in his or her hands. And, taking all the pluses and minuses, nothing is going to be a complete answer to a particular, you can't have one thing fit everything, one shoe fit everyone. So let's go on to the next case. Some important questions to be taken out here. One of the questions which Sandeep had asked about a glenoid osteotomy or a scapular neck osteotomy. But since we had a case, I thought we will bring it up when this comes here. Go ahead, Nolan.
So this is another approach to the problem. 9-year-old girl presented with marked trumpeting, and we have imaging that she has non-congruent glenohumeral joint, which would fit with a type 4 water schema. So she has marked trumpeting, limited abduction, and her posture is persistently internally rotated arm. And you can see the axial images that there is a pseudoglenoid and posterior subluxation of humeral head. So at the age of 9 years, it fits into a non-congruent glenohumeral joint, and if someone would like to, the conventional teaching has been to do a derotation osteotomy at this. And we tried, and I was part of the initial paper from Sick Kids, that we tried to address this with an glenoid anteversion osteotomy with soft tissue rebalancing, and trying to change the environment where a tendon transfer would not work to the one where it would work. And we typically take the glenoid neck osteotomy and put a graft either from the neck, angle of scapula or from the iliac crest. And so this were the paper from Sevan, Hopian and group published in 2012. And I started doing it with a IITV guidance. You know, many a times you in a very severe glenoid dysplasia, you are worried that you might enter into the articular surface, and we can do an axial imaging intraoperatively by using our image intensifier, and we can template our osteotomies so that we can prevent entry into the articular surface. And with the preoperative templating on MRI, we can do the grafting. And this is the result of this girl. Her trumpeting resolved, her abduction improved, her arm posture improved, and she could go behind the neck, and she maintained. I tend to do internal rotator release with a minimally invasive subscap release from the medial border of scapula. So I start with that. I fear to release the do conventional open slide from the lateral border, because the blood supply of subscapularis enters between teres minor and major. So that's how we have come to minimally invasive subscap release. So I start with that. Then that's the outcome. And this is 1 year follow-up. So the humeral head is well aligned. The glenoid version is restored, and that was the outcome. So your comments on this. So I do glenoid anteversion osteotomy in children between 4 and 10 years with non-congruent glenohumeral joint. The younger children have high remodeling potential, and even soft tissue rebalancing can give you this kind of glenohumeral joint. And children more than 10 years, we think that they have less remodeling potential, and we resort to external rotation osteotomy. I mean, this is my approach, but people have extended the indication of glenoid, and even Sevan Hopian, he now does this osteotomy even in adolescents. So there's another approach. Of the only thing we fear of doing derotation osteotomy between their less than 8-9 years is we fear that as we are not doing anything with intact and tight internal rotators, this deformity may come back. So that's why we try to avoid derotation osteotomy at a younger age.
Mm-hmm.
So what would be your take on this? Do you do any glenoid osteotomies, and what do you see the role of it, in the spectrum of OBPP?
I think it's fascinating. I have to say I have not done glenoid redirectional osteotomies like this. It is one of the things I thought was very interesting when I was preparing this talk and looking at the radiographic parameters is that there's this really long laundry list of all the things that get changed in brachial plexus birth palsy. And then similarly, the approaches to, well, how to quote unquote fix the problem, you can in fact approach it in so many different ways. And it's very, if you look at it, you can address the glenoid, you can address the entire, scapula and the positioning. You can, so it's kind of fascinating how different, how there's different ways of achieving very, very good results. And it's such a complex question in terms of, is one better than another, and what are the indications for one procedure being working better than the other. But obviously, in a child like this, if you're just doing an extra articular humeral osteotomy, you're in a sense giving up on this joint. You're saying it's too dysplastic. We're just going to let it continue to be dysplastic. And again, we do know that some of the children grow up to be young adults and who have persistent shoulder pain, and how much of that is the arthrosis happening at their shoulder versus something else. So if you can do a procedure like this and actually give this shoulder joint a chance of being much closer to normalcy, I think there's some excellent opportunities. I'll have to say for myself, I'll have to, I'm assuming there's a fairly significant learning curve and I'll be a little nervous about staying out of the articular surface in these really dysplastic glenoids and such.
Okay, so I think we've had quite a huge variety of things being presented so far. And as I see the clock, we're almost coming to the end of it. Thank you so much, Jennifer, for being there and sharing your experience and some nice, interesting things that came up in the thing. Time for Dr. Patwardhan's POSI Secretary's closing remarks, and everyone stay safe.
Thank you.
So I just want to take a brief moment to thank you for this opportunity. It was a wonderful chance to have a discussion about some very interesting topics near and dear to my heart, and I've learned so much from the panelists and everyone. Thank you.
Pleasure.
Thank you.
Thank you.
Thanks, Jennifer, for your time and your presentation, which nicely highlighted the approach that most of the general pediatric orthopedic surgeons should have at very young age. I saw that you were very aggressive at very young age with your releases and early nerve transfers, I would say, to restore function. And you did not talk much about doing glenoid osteotomies in very young age. The Molin showed at 9 years of age. And thank you, Praveen and Maulin, for your excellent work, and Rujuta for a superb moderation. And I thank everybody. And I leave you reminding you that coming Saturday, 7 p.m., we have another webinar by Dr. Bhave, who's a physiotherapist and is in charge of the rehab center at the Rubin Institute in Baltimore, who's going to talk about how to get maximum knee function after deformity correction and lengthening procedures. So that's Saturday 7. And on Sunday morning, we have a talk by Professor Kito from Japan. So we'll have a Japanese perspective, something absolutely new on how to tackle SCFE and DDH, something probably we've never seen earlier, some conservative methods and some unique things about a different approach to DDH and SCFE. So see you all then. Thanks, Jennifer, again, and have a good night.
Thank you so much.
Good night, everyone. Thank you. Thank you. So, okay, thank you so much, Dhiren Bhai, Sandeep.
Yeah.